Welcome to this webinar on how you can boost your practice with OCT. I'm Dr. Julie Rodman. We have all been through an unprecedented time with the development of COVID-19, and you're probably quite concerned about how your practices are going to survive financially. What I would like to do in this webinar is discuss some new and innovative ways that you can use your OCT to not only advance the care that you're providing for your patients, but also provide a new source of revenue for your practices. So you may be concerned that patients are going to postpone their routine eye exams, right? They're not going to want to come in and spend money on a routine eye exam, and that's a very valid concern. They may not want to buy frames. They may not want to spend money on luxury frames. They may even decide that they don't want to renew their contact lens prescription because they don't want to spend the extra money at this time. If you look at the graph on the right-hand side of the slide, the red line shows our overall concern of the COVID-19 virus. The yellow line underneath the red line shows patients' hesitancy in buying new eyewear during this time. And you can see that the two lines really mirror each other. So basically, the more concerned a patient is about the virus, the less willing they're going to go out and spend money on things that they don't consider necessities. So we must position ourselves to be medical providers, okay, to not only offer refractive exams, not only offer contact lens services, but also provide medical care. And again, use technology that we already have in our practices to elevate the care that we're giving, and again, also to provide more income to our practices. So the clinical pearl here is that we need to realize really the importance of building a medical practice in the COVID era, okay? Because the medical model is what people are going to embrace during a time when finances are tough. And how do we do that, right? How are we going to embrace the medical model, right? You practice every day. You may or may not be dilating. You may not be spending a whole lot of time on eye disease. So how do we do this? What is the first step? And really the first step is using the wellness exam. The wellness exam was created by OptiView to provide information on one platform or one printout regarding not only the optic nerve, but the retina. So you can look at this printout that the wellness exam will provide, and it'll give you preemptive or a summary of information about the patient, perhaps before you even see the patient. And really the beauty of the wellness exam is that if you identify something on the wellness exam that needs more care, you can bring the patient back and do more advanced OCT testing from that initial wellness report. So again, if you look at the question, why is this wellness exam so important? Because it's going to drive the decisions that we make moving forward about the patient. Right? If we find something on that exam, then we're going to want to do more with it. We're going to want to bring the patient back. We're going to want to run more testing. If you never do the exam, you don't know what you're missing, right? You don't know if the patient has something. So it's important when the patient's in your chair to explain to them that this test is going to provide us a summary of your ocular health. And that should be used to drive the exam forward. So this is a printout of what the wellness exam provides. And I'm not going to go into a ton of detail, but really just to summarize what I was saying before, there's so much information on this one report. You have 7 B scans, okay, you can see here. You have a horizontal cut, you have a vertical cut, and then you have 6 other horizontal cuts. So you can actually get a full assessment of the retinal health by looking at these B scans. Here you have a thickness report. Okay, it's going to take your B scans, it's going to show you on a micron scale how each part of the retina is doing. Okay, it's going to compare this data to the normative database. Okay, how much of the population has thickness or thinness as your patient has. It's going to give you parameters about the ganglion cell complex and compare it to the normative database. And this is all information that you can use moving forward to make decisions on future testing or future goals for this patient. The new wellness report is called the Angio Wellness Report, and it takes the old information, which I just discussed, so B scans, normative database information, GCC information, and now it introduces the angio piece. The angio piece is going to give us the information about how well perfused the retina and choroid are. Okay, so that the regular eye wellness exam is giving us information about structure. It's giving us information about elevations, undulations, thinning, thickening. The wellness report is going to now provide that in-depth analysis of how the patient's vasculature is doing. Okay, you can get a measurement of the foveally vascular zone. You can get a vessel density map. And not only that, you can get an objective analysis in a number format of all the findings that you're seeing here. So this is really an outstanding wellness report because it provides all of the regular wellness information now with an overlap of the angio information. And again, what I want to emphasize is that this is going to serve as the driving force behind what you're going to do moving forward. Are you going to order more testing if a patient has an abnormal GCC? Are you going to order more testing if the patient's foveally vascular zone is larger than normal? Okay, and I'm going to talk more about what this means as we move through this webinar. But having this preemptive information in one location, kind of on a summary report, is extremely helpful in driving the exam forward. So here's the million-dollar question. What might you uncover? And again, you might uncover pathology that is not visible clinically. Okay, patients may be symptomatic. They may not have any visible fundus findings, and your job is to become the detective, the diagnostician. What does this patient have, and what am I going to do with them moving forward? So this is an example. This is a 60-year-old white female who came in complaining of reduced vision, 20/30 vision. Over the last few weeks, my vision has gotten really quote-unquote weird in my right eye. And I magnified the macula here to show you that, honestly, it doesn't look very convincing of anything. So you might be thinking, well, she's 60, maybe she has a cataract, perhaps it's lenticular changes. So you look in and it's not the cataract, okay? She has some, maybe mild nuclear sclerosis, but nothing that would explain 20/30 vision. And I'm not convinced that the macula looks abnormal. So this is one of those patients, before the advent of OCT that you would be scratching your head, right? And you're not really sure what to do with her. But she did come in, right? She came in the middle of the virus because something was wrong. And you want to be able to say to her, Mrs. Jones or whoever, this is what is wrong, okay? So of course we run OCT. All right, and what is the OCT going to show us? Well, in this particular patient, you can see that she had vitreomacular traction, okay? She had point of attachment here, point of attachment here, very small area of obscuration of the foveal contour, which is why when you look at her fundoscopically, you really don't see anything because this is a very mild form of vitreomacular traction. But there is enough change, enough thickening here in the fovea to explain why she has 20/30 vision. Okay, so this may be a patient that you want to monitor. I would monitor her in my practice. But if you didn't know that she had VMT, you would not know why her vision was 20/30, and you would lose this patient. You would have to refer her out for further testing. Okay, so perhaps you ran the wellness report and you saw that she had VMT. Then you may decide to run a raster scan, or you may decide to run a grid report and get more information about the VMT. And then you can make a decision moving forward how you want to take care of the patient. And remember that every time you bring the patient back, every time you run additional scans, you're generating a new source of revenue for the practice. Here's another example. This is a 70-year-old Caucasian female. She's 20/40. And you look at the fundus and you say to yourself, well, why is she 20/40? There may be something there, okay? She tells you that she's had a recent onset reduction in her vision in both eyes, and that she just had cataract surgery. Okay. So, yeah, I mean, her IOL looks great, right? It's not the IOL. Is there something wrong with the macula? Well, there certainly looks like there could be something wrong. Maybe you're not sure. Okay, maybe you look at it and you're like, well, it could be. Maybe it's just that she's elder. This is another example where we're going to get OCT. This is an example of an eye wellness report. Well, perhaps you knew that this was an epiretinal membrane, but did you know that this epiretinal membrane was so thick, that this scaffolding was so significant that it was causing quite a bit of irregularity and thickening to the retina? You can see it on the thickness map here, the warm colors. The ganglion cell map is abnormal because it's affecting the ganglion cell complex. So this is a nice example of maybe someone that you knew looking fundoscopically that there was an epiretinal membrane, but didn't know the extent of it. Okay. And here's a patient that, again, depending on your comfort level, maybe you're going to watch it. Maybe you're going to refer it out. Remember, she's 20/40. But without this ancillary testing, you're taking a guess. Okay. You're thinking to yourself, I think I might see something, but I want some quantitative analysis. I want a better description of what I'm seeing on clinical exam, on fundus exam. Here's another example. A 57-year-old white female presents for her comprehensive exam. So at least she's coming in, right? She says, yeah, my right eye, maybe my vision's been a little reduced, but nothing terrible, right? And you look in, and this is the fundus exam. And you can see that she's got some soft drusen. They don't look too bad, okay? Couldn't really explain on that picture. She's complaining of a little bit of reduction in vision, but it doesn't look too dramatic to me. But remember that OCT is an outstanding resource in any patient that has drusen. It's going to give us a lot of information about the characteristics of the drusen, and oftentimes it's going to tell us that there's stuff going on subclinically that we can't see fundoscopically. So here's her wellness report. And you can see on the B scans on the top, the red arrows on the bottom here are pointing to drusen. Okay, this one looks like a little drusenoid PED. And it's telling us that, yeah, this patient has some RPE disease and it is affecting the macula. So that might be why she's complaining of reduced vision. She also has vitreomacular adhesion. Okay, you can see it here and here. So now you can make a better diagnosis. Right? Maybe you say this patient has early AMD. Okay, and you can drive the exam forward now. Do you want to bring her back and do other testing? Do you want to get some more advanced visualization? Do you want to get an OCTA? Okay, and really get an assessment of the vasculature. So these are all decisions you can make from this one report. What about using the change analysis tool, right? So here's again a patient that has a lot of soft drusen. You see them in 2009, and you can see here the drusenoid deposition. They come back 2 years later, and there's a significant amount of change in the drusenoid deposition. And each time the patient comes back, visually, you can see that that drusen looks like it's getting denser. The drusen are getting bigger. The drusen are getting wider. They're getting taller. And so the change analysis feature on the OCT, which I don't think is utilized enough, is really going to provide a quantitative way of looking at each of the drusen and comparing how that drusen has done over time. And why is that important? Because remember, when we're grading AMD, we're looking at the stability of the drusen. Are they changing in size? Are they changing in width, in caliber? That's going to drive really how we're going to diagnose and classify the disease. So here you can see that this patient came in July of 2012, and then they came in November of 2013. And what the machine does automatically is it lines up the scans identically between visits. So it's able to show you on 7 of 2012, this is what the retina looked like. And on 11 of 2013, this is what it looked like in the exact same location. And we saw on the pictures that, yeah, it looked like things were getting worse, but did we know how much worse? Well, now that we have this change analysis map, we have a great amount of information. You can see that the scan on the bottom here looks overall worse. Most of the drusen, especially if you look here, have gotten larger. Okay, look at this area. Definitely has gotten worse. Over here, the ISOS junction, the photoreceptor integrity line, looks a lot more irregular and mottled than it did here. So this is a patient that probably has moved on to a more advanced stage of the disease. And you wouldn't be able to say that just based on perhaps looking at the fundus exam. And you can see here that we can look at each quadrant surrounding the fovea. And if the number is positive, it means that that area, those drusen, have changed in size. Okay, so again, understanding what technology is available, what scans are available on the OptiView platform, and knowing how to use them to drive your management decisions. And again, this is definitely a patient that I would bring back to do OCT angiography on, right? We want to look at, especially areas like this, and make sure they're not developing any type of subretinal neovascularization or occult neovascularization. Let's look at this example. This is a 60-year-old Caucasian female. She was asymptomatic, okay? She happened to come in because she was due for her exam. She needed new glasses. And we notice on her fundus images here that there's an abnormal lesion temporal to the macula here, okay? She wasn't noticing it because it wasn't in her fovea. Her vision was actually very good. And this is going to show you the beauty of the wellness exam. So you look at her and you see something there, you're not sure. Is it old? Is it an inactive RPE lesion? Is there something going on in the choroid? So we get a scan. And here's her eye wellness report. And you can see in the right eye that she has an anomalous lesion here, an area of hyperreflectivity above the RPE, serous pockets of fluid above it and adjacent to it. We have a horizontal scan, we have a vertical scan. This is a patient that has developed a choroidal neovascular membrane, okay? And again, because it wasn't affecting her macula, she didn't even know she had it. So by running this eye wellness report, you are potentially preserving or saving the patient's vision moving forward. Okay, this is a patient that you're probably going to want to refer out for some type of intervention. But if you hadn't run this report and she was asymptomatic, then you never would have known she had the disease. Something I feel very passionate about, especially now in the age of COVID, is our Plaquenil patients. There's been a ton of talk about hydroxychloroquine. Does it work? Does it not work? Is it going to cause toxicity to our patients, not only ocularly, but systemically? So I think it's a good idea to remember what Plaquenil toxicity looks like. And OCT is honestly the very best way to monitor for Plaquenil toxicity. So here's a patient that comes in. She's 55 years old. She's on Plaquenil. And these patients tend to be really good about coming in for their exams because, again, they have a medical diagnosis. They might have lupus. They might have rheumatoid arthritis. So they're pretty good about coming in. And you look in and this is what you see. And you can see that there is a bullseye maculopathy bilaterally. So basically some preservation of the foveal kind of coloration and anatomy with this hypofluorescent area, which is really atrophy surrounding the macula, okay? Perhaps she's a patient that you knew had Plaquenil toxicity. Perhaps she's new to your practice. It's your job to look very closely at the OCT and figure out what you're going to do moving forward. Okay, we're going to co-manage with rheumatology. We're going to make decisions moving forward on how to take care of this patient. So here's the OCTs. The top ones are hers, but let's look at what on this bottom image for a minute. This is your normal OCT. You can see that the retinal anatomy of, I guess, the neurosensory retina looks perfect. ISOS junction ELM look perfect. Okay, this is a normal patient. This is on the bottom what your typical Plaquenil patient looks like. They get this collapsing of the neurosensory retina with thinning in the paracentral parafoveal macula. Okay, you can see there's loss of the ISOS junction, really attenuation of the RPE, which correlates with that hypofluorescent ring or the bullseye maculopathy that you saw fundoscopically. it lends itself to what we call a flying saucer appearance because you get almost an area of hyporeflexivity here due to the collapsing of the surrounding tissue. In our patient, you can certainly see attenuation in the parafoveal area in both eyes. These little areas of hyperfluorescence here are photoreceptor death. Okay, some little pieces there, some RPE disease, and also this flying saucer sign centrally. So this is a patient that has significant plaquenil toxicity, and we have a big role in taking care of these patients because if they have disease, it's something that their rheumatologist needs to know. And so I did a whole webinar on plaquenil and plaquenil toxicity, but I think that this is a huge area that optometrists really need to take the rein on. We need to be aware of risk factors. We need to be aware of dosages, duration of use, and education first and foremost for our patients. So this is another kind of disease state or medication toxicity that we can take care of. This is a medical problem that optometrists can take the reins on. Diabetes is something that I feel like we really have so much potential to do so much for these patients. Again, using OCT that oftentimes we forget about. So let's look at some examples here. Okay, we all know that kind of the old way of looking at diabetic macular edema was using what we call clinically significant macular edema. But since the advent of OCT, the new way, the better way of assessing a patient's stability or outcome is by looking at the macula, looking at what that foveal area looks like. Okay, is there macular edema affecting the center of the fovea or the center of the macula? We would call that center involving diabetic macular edema. If they had cystic spaces outside the macula, we would call it non-center involving diabetic macular edema. And really, you need OCT to classify, center involving or non-center involving. You can't just look at an eye fundoscopically and see where the cystic spaces are. Okay, so looking at this OCT here, this patient certainly has center involving diabetic macular edema with a neurosensory detachment. And you can see on the thickness map here that there's certainly an area of thickness right at the fovea. And why does it matter? Why do we care if a patient has had center involving or non-center involving DME? Because center involving DME has a 10 times greater chance of developing vision loss than non-center involving DME. So we don't want to use kind of that CSME term anymore. We really want to use our OCT to classify these patients correctly. Okay? And this is very, very important. Here's a patient, a diabetic, who was 20/20. Okay, and again, the diabetic patients are pretty good most of the time about coming in for their exams. They know that they can have vision loss. So this is a patient that you happen to see that's 20/20. You can see that there's some background diabetic changes. I would call this mild. Okay, there's a Don blot hemorrhage. There's some microaneurysms. There might be one cotton wool spot there, which would put it into the moderate category, but really not a ton of diabetic retinopathy here. I certainly think that the macula looks good. In fact, the macula probably looks the best of the whole picture. Okay, so before the advent of OCT, you probably would bring this patient back in 8 months, maybe a little before that, depending on your comfort level. But again, with the advent of OCT, the best way to take care of these patients is to get an OCT. Okay, because you want to make sure that that macula is not involved, that we're not missing intraretinal cystic spaces that would put them kind of in that category of having macular edema. So here's the eye wellness scan. And what are we uncovering? We're uncovering cystic spaces, okay? And they're very close to the macula. So this would be a patient that is, more at risk than I originally thought. This eye wellness report is giving us information about this patient that I would have missed fundoscopically. I did not think that the macular area looked dangerous at all. Okay, the macular area actually looked the best on the picture. So introducing this scan and now bringing this patient back for more advanced testing. Okay, doing more advanced scans, perhaps getting OCT angiography on this patient, measuring the size of the foveolae vascular zone, measuring the vessel density, using those quantitative parameters to see how this patient's going to do over time. Okay, and again, just to emphasize the point, yes, we could call it CSME, but do we know what the prognosis is just using the word CSME? No, we want to classify it as center or non-center involving DME depending on the OCT findings. The other thing that we need to take the reins on is don't refer out all your glaucoma patients. Use your OCT to take care of glaucoma. Okay, it is an outstanding tool, and OptiView has some amazing features that other technologies don't have to help us to really kind of look at the conversion and progression of these patients over time. This is a 59-year-old African American male. Okay, it's obvious that this patient has cupping. You can see that I'm pointing with the red arrow here. Inferior temporal, there is some thinning. Okay, this left eye doesn't look quite as bad, but there certainly looks like there's thinning inferior temporal in both eyes. Okay, so what? We know that this patient is a glaucoma suspect. What do we want to do with them? How can we keep this patient in the practice, right? So, the old way, I should still say the new way because we still use visual fields, is get a visual field. And you can see here that there is a superior defect correlating with that thinning that we saw on the fundus image. Okay, but what other information can we get? Okay, how can we use our OCT to take care of this patient? All right, so here's that, what we call the OU report. Gives us amazing information. It gives us GCC information, gives us RNFL information. So here's the optic nerve head. Recall that inferior temporal thinning. This is the right eye. Well, there it is on your RNFL. There it is on your GCC map. Okay, it correlates. It's showing you that, yes, this patient does have thinning. They're outside of the normative database in that area. The left eye didn't look quite as bad, inferior temporal, but there's still thinning. And you can see the GCC is picking it up temporally here, and it's showing up on the RNFL. Okay, so how do we use this information to make decisions about this patient moving forward? Well, for those of you that are familiar with the OptiView technology, we have this index called the FLV, focal loss volume. The focal loss volume looks at the patient's GCC, and it's based on the premise, again, that glaucoma affects focal areas in the ganglion cell complex. If the FLV is red, it's indicated this patient has a very high percentage of converting to glaucoma if they're a glaucoma suspect. So here's a patient that has red FLVs in both the right and left eye. So this patient has over a 50% chance of converting to glaucoma. So that's a very powerful tool. We want to use that tool to help guide our decisions about this patient moving forward. And what's really interesting is remember that the visual field wasn't even showing us an abnormality in the left eye. It was saying, yeah, the visual field looks fine. You might not have initiated any treatment in that left eye. But now that you have this very powerful tool here, that again is exclusive to this technology, you may decide to intervene in a more timely manner. Okay? And again, this is what I was just talking about. It helps predict conversion in suspects, which this patient was a suspect, and it helps predict progression in a patient that already has glaucoma. Okay, so very powerful. We also have the ability to look at patients over time, right? So up here you have the patient's GCC map that you can look at over time. Each time the patient came in, it's over here, each visit. Remember that we want the ganglion cell complex to have a nice green ring around the fovea. The fovea is black because there's no ganglion cells there, but 50% of our ganglion cells are around the fovea, so we want a nice green donut. This one's missing a little bit over here on the temporal side, okay? And you can, again, look at this over time. You can also assess the RNFL over time. There's the T-SNP map. Remember that the T-SNP map should have a double hump because the thickness of the RNFL is going to be greatest, inferior, and superior. So we have a lot of tools here to see how a patient's doing over time. We have the rate of change maps on the bottom that will indicate or tell us if there is a statistically significant rate of change. So don't forget to use these tools to bring the patient back, to really take glaucoma by the reins and not refer it out. Remember that these are billable procedures every time you bring the patient back, and it's going to generate a new source of revenue if you have not been taking care of glaucoma patients in the past. This is another beautiful example of how you can use OCT to help you determine if a patient has glaucoma. So here's a 65-year-old white male, and the question is, does he have glaucoma? Well, he certainly has more cupping in his right eye than his left eye, but is it glaucoma? It looks awfully healthy. They both look awfully healthy. There's a lot of rim tissue, doesn't look to be any wedge defects, healthy eyes. Is it glaucoma? Let's pull in the OCT. Here's the OCT analysis. And what I want to emphasize here is that you might have thought that the OCT only gives us GCC information, RNFL information about conversion and progression. But you know what else it does? It measures the size of the optic disc. What are we noticing here? Optic disc area. We're noticing that the right eye is a 3.10 and the left eye is a 2.70. What does that mean? It means that a patient that has a large optic nerve head is allowed to have a larger cup without having glaucoma. They essentially have megalopapillae, or a large optic nerve head. So here's a patient that you may have started treating for glaucoma due to asymmetry in the cupping, but you would have made a misdiagnosis because all this patient has is an anatomically larger cup, larger optic nerve head in the right eye than the left eye. So another amazing way of really honing in on making the correct diagnosis. Okay, here's a patient that may have been treated in the past, was on numerous medications. This test, look how everything is green here. FLV is green. This patient doesn't have glaucoma. Okay, this patient does have asymmetric cupping, and they have asymmetric optic nerve head size that you can quantitatively assess here using OCT. What about our anterior segment application? So here's something that most practitioners don't even know is on the machine. And if they do, they're not familiar or comfortable using these tools. And this is such a great way to use the OCT, bill for procedures that you need them for, make accurate diagnoses. Okay, pachymetry. What if you don't have a pachymeter in the office? You can use your OCT to get pachymetry. Here's your pachymetry map on the bottom, and it is so easy to take. You get a cornea scan, and it automatically gives you corneal thickness at every area on the cornea, 6 by 6. This patient has a thin cornea, and again, you can see that because it's blue. All of the information you need. Okay, so you may not be using this for pachymetry. Your pachymeter might be broken, and you might be telling the patient to come back when the pachymeter is fixed. Well, guess what? You can use your OCT. And it's extremely reliable. There have been many studies done comparing OCT pachymetry to using a PacMate or one of those other tools, and this is extremely, extremely reliable. What about assessing the cornea, right? If you're familiar with the different layers of the cornea, then if a patient presents with a dystrophy or a degeneration or an opacity on the cornea, you can localize where the problem is and again, make a better diagnosis. Epithelium being the most superficial, Bowman's right underneath the epi, the stroma, and the endo. Okay, and again, understanding the locations of the different parts of the cornea to help make diagnoses. So here's a 48-year-old African American. She comes in. I got decreased vision, doc. I can't seem to clear up my vision. And you look in and you can see that there's definitely a problem with the cornea. But you don't know what it is. Yeah, I learned all the dystrophies in school. I remember there's stroma, there's epithelial. I don't even know what layer this is affecting. Well, guess what? Your OCT is your best friend. Put this patient behind the OCT and get more information. This is her OCT scan. Okay, what are we finding? We're seeing opacities here, big hyperreflective lesions. And where are they? They're from Bowman's all through the stroma. And if you know your dystrophies, or if you're at least familiar with some of the dystrophies, it should ring a bell that this is what granular dystrophy looks like. Okay? And what is this line telling us here? On the optic view, that line means that you have a good strength signal, a good scan. Okay? That's the tear film. So again, utilizing the OCT to localize the depth of the lesion and to help us make a diagnosis. And then you can figure out, okay, she's got granular dystrophy. What am I going to do management-wise? Okay, am I going to initiate a medication? Am I going to refer her? But if you hadn't done the scan, you would have had to refer. I'm not sure what it is. Now you've obtained new information and you've billed them and generated some income based on this patient. What about this patient's cornea? Again, we know that there's an abnormality. There's all these white opacities. Is it granular? Is it something deeper? Right? Patient's got decreased vision. There's a scan. And you can see that the abnormality is localized to the corneal endothelium. Okay? This happens to be mutton fat keratoc precipitates from chronic uveitis. How interesting is that? Right? Who would have ever thought that we would be able to visualize this? You might have told this patient, yeah, you have a corneal dystrophy. This is not a corneal dystrophy. Okay, this is an indication of chronic disease, chronic inflammatory disease, using your OCT. This patient, another patient, linear opacities on the cornea. Again, do you remember what the linear opacities are? What dystrophy is it? What could it be? This happens to be lattice. And again, you can see here that it is a stromal dystrophy. It's affecting the stroma. Epi is healthy. There's a little bit of cavitation in the endo here, but this is a stromal abnormality. Yet another, right? Look through the layers of the cornea. Epi looks good. Bowman's, stroma. This is an endothelial problem. This is gutata, okay? Fuchs. So again, I can't emphasize enough. Think about all these patients that come in, whether they have a corneal foreign body, they have something funky on their cornea, and you're not running OCT. This is another source of revenue. Take advantage of your OCT. Get a baseline scan. Then you can scan them every year to check for the stability of the condition. How does the cornea look over time? What about the angle? Right? Another thing that we can use this as a way to determine if an angle is open or closed, right? If you have a patient that can't tolerate gonioscopy and you need some type of way to determine, are they safe to dilate? Use your OCT. You can see here, this is the cornea. Here's our ciliary body. Here's the angle. This is a wide open chamber. That's a normal angle. This patient, you can see, has a narrow angle. All right. Again, understand what technologies are available and how you can utilize them in your practices to, again, not only take the best care of your patients, but bill them for what you're doing. Okay. The last part of this webinar, I want to talk for 1 minute about the Angio platform. I know that not everybody has it, but this is really the best way to minimize referrals, because this is a way to really drive home a diagnosis without getting fluorescein or ICG testing. So this is such a beautiful OCT angiography scan right here on this page. I look at it, it makes me very excited. So diagnose more disease in your practice and minimize referrals. So what are we seeing? This is a patient that has diabetes. Okay, this is a patient that perhaps we looked at fundoscopically. I'm going to show you an example, but thought they looked great, but we're detecting microvascular changes at such a high level of visibility before they are visible clinically. Okay, here's the example. Here's a diabetic patient, 49-year-old African-American female. Her fundus looks really good. Okay, she's got literally one little heme that's visible clinically. Okay, she's been a diabetic since the age of 14. Her blood sugar is 121, which is good. Her A1C is all over the map, 6.3 to 9. All right, we want it to be below 5. All right, so what do you do with this patient? Her vision's good. She's got good control for the most part. Her blood sugar is good, but I don't want to say that she has good control. Her A1C is elevated. What do you do with this patient? So this would be a patient that I would likely say, I'll see her in a year, right? I don't see anything fundoscopically. What am I bothering her with? Why do I need to keep bringing her back? Okay, so I would say to her, You're doing a fantastic job. Whatever diet, whatever exercise program you're on, you're doing very well because you've been diabetic for 30 years, 30 plus years, and look at your fundus. Okay. However, are we missing something, right? Is there a missing piece? And the answer really is a yes. This is her OCT. This correlates with what we're seeing fundoscopically. Structurally, she looks great. Structurally, there's no evidence of thickening. Everything looks healthy. Okay, she may have some hyperreflective areas, maybe from the hemorrhage, but overall, if I were to have gotten this scan on this patient, this would be a patient that I would feel comfortable with bringing back in a year. Is that the correct management plan with this patient? Well, when you look at this, the answer is no. This is a normal angiogram of a patient's superficial plexus and deep plexus. And without going into a ton of detail, in our diabetic patients, we want to analyze the superficial and deep plexus because these are the inner retinal perfusion. These slabs are what kind of identifies or illustrates the perfusion to the inner retina. And because diabetes is an inner retinal disease, these are the slabs we want to focus on. Look at hers. Okay, you notice a lot of things. You can see that there are large areas of non-perfusion. Those are the black areas here. Again, compare this to this. There are these hyperfluorescent or white areas here, which are microaneurysms or capillary outpouchings. Okay, there is a lot of enlargement of the foveolae vascular zone in both of the slabs. So again, comparing her to the normal really shows you the extent of microvascular damage that this patient has. Okay, initially we thought she was fabulous, right? Everything looked pretty good on her structural scan, on her fundus, but look at the angiography. We're missing so many pieces. You can even look at the foveolae vascular zone and get a quantitative measurement, right? So this was, I told you before, her foveolae vascular zone looked much larger than quote unquote the normal. And the machine will even tell you how large it is. And this number can be used to categorize the level of retinopathy. Okay, and 4.443 is a large FAZ. Now for her it might be normal, but what's even cooler is that over time you can assess the FAZ and see if it's remaining stable, right? If it's changing every year, then this patient's retinopathy is getting worse. Okay, so it's a new way to take care of our diabetic patients. What about AMD? What about patients that have CNV? I would say that this is, again, one of the most wonderful things about OCT angiography is that we're finding lesions that we never knew existed in patients that were asymptomatic. This is a choriocapillaris slab, and you can see this little baby here. That is a membrane. That is a choroidal neovascular membrane. Here's a patient, a 66-year-old African-American male who I brought in because he was a glaucoma suspect, never expecting to find anything in his retina, right? I was looking at the GCC. Yeah, the GCC might be abnormal from glaucoma, but I wasn't expecting anything else. Here's his OCT scan, and you notice this very, very tiny area of abnormality right at the macula. Well, guess what? Before the advent of OCTA, I would have said, okay, it's some drusen, it's some RPE disease. I wouldn't have done anything with it. Well, this machine has certainly humbled me because when I do angiography now, or when I did it on him, when I scanned the choriocapillaris slab, which is where this RPE choriocapillaris abnormality is, I found this little lesion. Okay, and I still look at it and I still say, wow, that is incredible that the machine picked up this anomalous area of vasculature that I certainly would not have picked up on spectral domain OCT or on fundus exam. Okay, and these patients, if you read the studies, actually have a higher percent chance of converting to a real big CNV or a true CNV, an exudative CNV over time. So it matters that we're picking up these abnormalities. It matters that we're finding these things in these patients. Okay, and look at this. You can assess them over time. This was the initial presentation where I picked it up for the first time, and I had the patient back two more times, and you can see over time exactly how that lesion is doing. Okay, has it changed? Is there now exudation? Is there now leakage? What are you going to do with the patient? But remember, if you had never run this scan, you never would have found it. And remember, if you had the Angio Wellness platform, you would have picked something up at the first glance at the patient, and you would have known that there was an abnormality. And that again would help us to drive our management decisions forward. So really, I hope that this webinar really gave you some light in this dark times, and it gave you some ideas about how you can use your OCT the best way that you can. Use it for anterior seg, use it for angle, use it for cornea. Take care of your glaucoma patients. You have so much information in your OCT machine to help you to make management decisions. Use all of your retinal scans to really get advanced interpretation. And if you have angiography, oh my goodness, get angiography on all of your diabetic patients, all of your glaucoma patients, all of your patients without a retinal disease. You are going to uncover so many amazing things that you wouldn't have seen without it. So in this era of COVID, take advantage of the technology that you do have. Learn to bill for things that perhaps you weren't billing for in the past. Don't send your plaquenil patients out. Learn how to use your OCT to take the best care of your patients. Thank you so much for joining me today, and I hope that you all make it through this very trying time with lots of health and great times with your family and friends. Be well.